My name is Patrick Treacy. I'm visiting professor of dermatology, and I'm speaking to you from Dublin. Thank you for inviting me to the second international conference on dermatology and skin. And we're going to look today at complications over the last 20 years or 25 years in aesthetic medicine and how we treated them. So these complications will run from Botox, derma fillers, all the way through to what happened during COVID, where we had to treat some of the patients with methotrexate that developed nodules, or even the first pandemic, which was HIV, which also was a global pandemic, probably before treatment worse than COVID was, and we had to treat these patients because the antiretroviral drugs at the time caused a condition called HIV facial lipodystrophy. So we treated this originally with Sculptra, but it left the doctor at risk of getting needle stick in the days before treatment. Was very satisfactory, and we used bioactin, which caused its own problems. So let's look at, I suppose, 20 years of complications. It's now really 25 years.
This is a wonderful idea, and for all of us that are just joining aesthetic medicine recently and seeing the problems, particularly with delayed onset nodules or also vascular occlusions, let me tell you that since 1999 I've been dealing with these and other problems of a much bigger scale. So what I'd like to do, I suppose, in this lecture is to take us back over the last 20 years of dealing with aesthetic complications. This, I suppose, is the start of it, and this is a very interesting photograph. This was taken at the Royal Society of Medicine recently, where I was chairman of the Congress, and you can see two of the people in this photograph have got hemifacial autologous transplants. This lady, you can see, with her cheek, and this lady with her forehead, and I'll go into that in a moment. So this is my biography. Over the last 3 years, I've won, I suppose, a lot of awards and medals in aesthetic medicine, and we can pass on through that to 20 years history of complications. Where are we now? So I'm going to start with botulinum toxin, and as you know, we don't get too many problems with botulinum, and even if we do get a problem, it tends to wear off. So it is ironic to an extent that nurses, for instance, aren't allowed to inject botulinum toxin in most countries, but they are allowed to inject dermal fillers, as are beauticians to an extent in Britain and even in Ireland. And beauticians are causing a lot of the problems we're seeing, and how they're allowed to inject dermal fillers into vascular systems, particularly arteries, is beyond most people's reasoning, but this isn't what the lecture is about. I'll just look at this. Case 1 was a patient that came to me. This was back in 1999, 39-year-old female, and as you see, she had ptosis in one eye, or eyelid. And believe it or not, she went to a dermatologist in Dublin who had told her that this was a permanent condition before she came to me, and this was quite easily solved with just a few drops of iodopine, and as a consequence, after 2 or 3 weeks, it had resolved itself. So this doesn't happen very often, certainly one in the thousands, and at the time I wrote some articles because people were afraid of Botox in the community, and my good friend, the late Andreas McEntee, had asked me to write a series of articles for the Irish Medical Times showing that botulinum toxin would be the new penicillin of the 21st century, as it has proved to be. So in 1996, QMed produced Restylane, and I'm just not mentioning it from a promotion point of view, but it was the start of the hyaluronic acid fillers. So as a consequence, because I'm dealing with complications, I'll sort of mention them. This is one of my own patients, and this patient here got fillers 1 week before she got married, and she had an allergic reaction, and as a consequence, she just got some steroids, and it had cleared up within 48 hours. This is a patient I've seen very recently. She was sent to my clinic with this type of reaction, and even though you see these pictures posted all over the papers, this is quite easy to treat. It's a hypersensitivity reaction. This patient had angioneuronic edema as well, so in her history. So I thought it was preferable to give her some adrenaline as well as some steroids. And by the time she'd reached home, which is about 3 hours from Dublin, her problem had cleared up. Again, I don't want to mention compounds, but I suppose I have to an extent, because these were the problems that we had, and these are the problems we grew up with. This patient here had granulomas in her face. I don't want to stay on our images for too long, because I'm aware that this is an aesthetic summit that can be picked up on mobile phones. And her granulomas had to be treated. Now, the polylactic acids, unfortunately, if you put them into circular muscles, then they could precipitate out crystals. And this caused a lot of problems at the time. Next patient was from Spain, and at this time, back in 2001, the world was facing a crisis with HIV, that it still is, but I suppose less focus has been put on it by the newspapers. And at that time, I suppose the only treatment for HIV lipoatrophy, and we didn't know at that stage whether it was going to be as a consequence of patients living that long with their illness, or whether it was secondary to the side effects of the medicine. So I'll just run into a little bit of the history of the time. At the time, you can see that I was writing sort of some articles on HIV, and if anybody reads my memoir, they will see my particular interest in that disease, particularly in Africa. So we were treating the patients with HIV lipoatrophy with Sculptor or the polylactic acids. But we had three big problems. The first thing is that we couldn't trust the medical reports that we were getting in from different countries. They were all saying it was the CD4 level was fine, and that the viral load was negligible, that they weren't infectious. But I had worked on cruise liners in the United States where I'd seen the same thing for patients, particularly coming up from South America, who wanted treatment in American hospitals with the newer antiretroviral drugs. So a patient could easily, unless you were in direct contact with the doctor, bring you in false medical records. The second problem, of course, was that to do Sculptor at the time, they needed 5 treatments. And the third thing was, because as anybody that has used Sculptor knows, the needles stopped blocking all the time, so you increased your risk of a needle stick injury from HIV dramatically. These patients needed up to 100 injections within the dermal layer, and as a consequence, we had to come up with a new way of doing it, because at the time there was recognized needle stick injuries, and we came up with bioalchemate. Bioalchemate was a product of the period, and we treated HIV lipoatrophy. I've had to reduce, I suppose, the possibility of patients being recognized in this. So at the same time, what had happened was America had invaded Afghanistan in 2003. This is me in New York 1 week after the bombing of 9/11. This was an article that I'd written on it at the time for one of the medical magazines. But at the time, we started getting patients in that had been injured in Afghanistan particularly, and we were using bioalchemate. So in that period also, HIV was causing immense suffering on the African continent, and it went across the whole sector from the point of view that parents were leaving orphans, particularly in Zimbabwe, on all that coastal route from the Zambian copper mines down to Cape Town. All the lorries had prostitutes en route, and that's what a lot of the concentration was. I include this only because this is Dr. Alex Catino, who was head of the task force in Africa for HIV from Makerere University in Kampala in Uganda. And Bono had gave him the United Nations Humanitarian Award for his work in Africa. And I got to know Alex at that time. And because we were seeing so many HIV lipoatrophy, I really wondered, was it the drug or was it a progression of the disease? So at the time, I had looked at Alex's work, and this is some contact we had together back now 14, 15 years ago. And so when I went down to Uganda, I realized that the patients I was seeing there didn't have this condition. It was very much a Western condition. So I presumed, or I advocated at the time, that it probably was the drugs that was causing it. It was later proven, probably about 2006, 2007, that it was the peroxide radicals of the antiretrovirals. And as a consequence of that, new drugs came out which didn't cause that transposition of fat. But at the time, it was a big period problem for us. This is the first patient I treated in the United States with bioalchemate. A wonderful guy. He went on a cruise liner after that. He'd been socially isolated in a room for 4 years, and I believe he may have even got married in that period, but I'll sort of move on. So this is a paper I wrote in the British Journal of the Journal of Derm Surgery at the time, where we had taken, I can't remember at the time, maybe 11 subjects with HIV, and I wrote a paper on bioalchemate, and it made it so easy because you could treat the patient in 1 day, the compound lasted for life, and the patient didn't have to come back, but life wasn't all that easy. As you know, the next problem we had, that bioalchemate started causing steroid facial abscesses, quite dramatically actually, and some of the patients we didn't see until 10 years later. The compound has now been taken off the market, particularly after the Canadian board had made complaints against the company. So this is one of the patients, and this is the way I suppose we could treat them. So when the compound presented, it presented like this, and you can see when you point it, you can see that it's white, and just nicked it, and the product came out. So we had so many of these patients to treat in this period, particularly.
This is removal of bioalchemate from the face. You can see that it's usually underneath the skin, and it's easy.
So then I was invited to Moscow as one of the first, I suppose, lectures back in after communism had ended. And when I was there, I was lecturing on that period where we had fibroblast transplants under esologen, another compound that has been pulled off the market. And at the time, I noticed that we were having a lot of doctors coming to me with problems with bioalchemate, Aquamid, and also we went through this period of nodules in people's lips, 2004, and so there was quite a lot of these, including infections. So just because people are seeing now all these problems with lips, believe it, we had it 15 years ago, if not 20 years ago, and you can see lots of different things. Again, I wrote a paper on this, advocating that polyvinyl should not be used in lips, and I wrote up again some papers on this. Now, at the time also, I noticed that radiesse was causing problems in lips, particularly, and I advocated that maybe it should not be used in the perioral area at all, particularly the perioral commissures. So this is us in 2007 at the Seafield Conference, where I advocated two things: the use of, I suppose, lidocaine with radiesse because it was a painful compound, and also to not put it in the glabellar or in the perioral area. And I believe this famous case was related to the compound we mentioned in this area, but I'll not go into that for obvious legal reasons. So the next period we had then was mad cow disease. And mad cow disease was very important because of the fact that America was still using collagen, and they hadn't still went with the hyaluronic acid fillers. The hyaluronic acid fillers we had from 1996. In the United States, they put them under FDA trials about 1999. The trials took about 7 years. So still in this period until 2006, mad cow disease was rampant. Now, mad cow disease was important for two reasons. The first thing is the American doctors were getting their collagen from the hooves of cattle in Texas, and of course from roosters' combs. And what happened after mad cow disease? Of course, bird flu. So this almost wiped out the potential for, I suppose, the collagen to be used as a filler in the United States. It still is to an extent, but it can't compete with hyaluronic acid. It only lasted 3 months. It could cause an anaphylactic reaction. The potential for particularly new avian virus being in it was possibly there, and don't forget that had transmigrated into the human species. So the new hyaluronic acids were advocating 6 to 9 months, 9 to 12, and even the newer ones now 1.5 years. So at the time I'd written some articles on avian flu and SARS. This was in 2005. The present generation probably watching this lecture will have never even been exposed to the problems we had during that period. But believe you me, they were probably worse than the problems that we're experiencing now. So case 10 was removal of hyaluronic acid. So nobody really had used hyaluronidase to remove it, but we were using it 15 years ago, back in 2005. And at the time, I had written protocols for hyalase, which are very important now. And this is a period, I suppose, where derma fillers were showing problems in patients, particularly if they went into the angular artery, the ilar artery, branch of the facial artery, all the way up, with a potential even in later years to cause blindness. So at the time, Arnie Klein, the late Arnie Klein, who is still alive, was treating Michael Jackson, the late Michael Jackson also, and he had put a little bit too much fillers in the face, and as a consequence, Michael needed it taken out. And I suppose most people know that he flew across the Atlantic, and we had to take it out. I only mention him during the lecture because, believe it or not, he was one of the first patients in the world that hyaluronidase was ever used on. As well as that, when we contacted QMed at the time, who made the product involved, they had no protocols and they knew of nobody that had actually used it to reverse overfill of a hyaluronic acid filler. So after that, hyaluronic acid was used for breast implants, and this was a wonderful compound. You could actually do a breast in something like 10 minutes, and it would last, at the time, if I remember, up to about 18 months. I was using it for some more interesting things, like pectus excavatum, and you can see this patient here with, I suppose, the heart involved to an extent. You can see how it was, I suppose, moved within the thoracic cavity as a consequence of the pectus excavatum, and without letting the patient's pictures be seen, I was using it more medical than cosmetic at the time, but it caused its own problems. So then the vascular problem started, and particularly the vascular problem started because most of the fillers we were using were non-reversible. So this is a patient I don't want to harbour on them that I had seen at the beginning of this journey. And then I was writing a paper on using derma fillers for atrophic scarring, and this is a patient of my own. I had this little bleed. Within a small period of time, it had gone into this reticular pattern formation where you had hyperemia, and within a very short period of time, a few days, you could see this crusting in this. This patient thankfully recovered totally. Possibly the transverse facial artery involved by the distribution of the network. This is a friend of mine at the time. She was Julie Bass. Julie, if you're watching this, hi. I know she had a hard time in California with the fires recently. She was the first patient to allow photographs to go onto social media and the internet. And you can see that this area of her face was compromised, and Julie later met me in Dublin along with her lovely husband and her lovely family and husband, and thankfully all is well now. This is a patient that I had seen myself, and I had written up hyaluronic acid. So this is one of the first papers in that period that had reversed a vascular occlusion, and when we started writing the protocols, this is a patient from Chicago, I'll not dwell on it, that was involved. And again, I'll not labour on this, but this was the start of biofilms, which became a problem in that period. And this was testing dexamethasone against 5-fluorouracil, and you can see the one that happened there. This patient here was referred to me from one of the hospitals with gross biofilm in her face. I'll not stay on it too long, but it took me 3 months to clear that. And at the time, I had done 2 different things. The first thing is I'd use dexamethasone to break down the capsule. The second thing I'd use inhalase to break down the compound underneath the capsule. And the third thing, I advocated the use of antibiotics, Clasid in this instance, and rifampicin. I treated the patient as if they had tuberculosis, maybe, from the point of view that it's encapsulated. The ordinary antibiotics can't work against the target microbe because it's protected. So we went in to break down the protections and with the highlights. And thankfully, maybe biofilm in that period was overrated a little bit. So then we had the problems of vascular occlusions involving blindness, and thankfully Jean Carruthers and some of our other colleagues were able to highlight the cases around the world. This was an interesting patient. We seen her at the very beginning, Carol Byrne, and she had written to me, you see in that period, and Carol had got some silicone injected into her forehead, caused this gross reaction, and she was treated in the UCLA craniofacial unit by Reza Jari and another colleague of mine from Northern Ireland, and Dr. Brian Boyd. And you can see here that she got this face transplant, or semi-facial transplant, autologous, and this is her with myself in the Royal Society of Medicine just a few months ago, actually. She flew over to London and then over to Ireland, and that goes to show you the sort of problems that existed, I suppose, during that period. Then I had developed a thing called the helper technique, where if a patient presented with quite marked, I suppose, partial or impending necrosis of the area with sloughing, secondary to vascular occlusion, we put this patient in the hyperbaric oxygen chamber, and then I brought in this technique, I suppose, where we could use PRP. One of the problems I've always advocated with either burns or vascular occlusions is that the normal healing process cannot occur. As a consequence of no blood being there, then epidermal tissue can't form. And in one of my other lectures later on, I'll go into that. So we advocated the use of PRP in the patient, and one of the problems with PRP per se, of course, is that you get a very marked vascular, because one of the growth factors is the vascular fraction. And as a consequence of that, I knew that once I restored our epithelium, it was going to be quite vascular. So what we done was we dampened that down with IPL over a period of 3 treatments over 9 weeks. And then you can see that the tissue that formed was still with a lot of open pores and all the rest. So I used on that a CO2 laser, and she came out with no scar. We treated 8 patients subsequently with what I call the helper technique. So that was written up there. Then we had to form some protocols regarding hyaluronidase. So there was an expert panel in Las Vegas in 2011, and we came up with using probably hundreds of international units, particularly of hyaluronidase, up to 750, I sort of advocate. This is a case I don't want to labour too long on. Came to me, or through me, from Sweden, and it was a patient who had developed monocular blindness as a consequence. What we thought at the time was some of the embolism occurring in the cavernous sinus rather than in the retinal artery. So at the time, this patient was receiving stem cells in Baltimore, or in Florida, but she was from Baltimore. This was a multiple sclerosis patient who potentially could get better anyway. It reminds me, in the Irish papers this morning, there's a case of, in one of our holy shrines, Knock, what they're putting down as a miracle. Again, a patient who had multiple sclerosis. These patients spontaneously go into remission. And so it doesn't really impress anybody medically, but to claim this as a consequence of stem cells, I believe the people involved have since had their license pulled. But at the time, I was also in South America, and I suppose I was with a stem cell expert, Alvaro Scupin, along with his wife, Nancy, who run a center in Florida and also the Dominican Republic. So we were going to send the patient there, but then the Caroline Institute had this problem with this doctor, Paolino Macchiarini, who was doing these esophageal transplants. I had seen Paolo in the Royal Society of Medicine. Unfortunately, his research didn't prove to be as valuable to medicine as we thought it was going to be. And some of his patients, I think, had died as a consequence. And Caroline Institute had sort of pulled. So that's a history of complications. Where are we going? We're going to look at that in one of our next lectures. So what I had done was, for one of the next lectures, is to look at the helper technique. And of course, the helper stood up for hyperbaric oxygen, epithelialization, Li light, P was the platelet-rich factors. And so what I decided to do was add in mesenchymal and stem cells to see can we get a better result. So certainly I will look at that in one of our other lectures.